Thank you everyone for joining us for our third session of opioid risk assessment, eating the elephant one bite at a time. I am Stevie Tsai, a pharmacist with Mountain Pacific Quality Health. I am thankful to be your host and speaker for this series. I'm joined today by my colleague, Deb Anderson, and then Kevin will hopefully be joining us from Sync Health as we continue on. We are having some technical issues, so bear with us if Kevin's not able to hop back on, but we're going to go ahead and get started today. Our past sessions, we have focused a lot on talking about the background of opioid risk assessment and getting some of these series learning objectives out of the way, looking at current status and trends of opioid use disorder and substance use disorder, the way that that impacts our patients. And then we've briefly touched on some different ways we can integrate some electronic health record tools and prescription drug monitoring tools into our workflow in order to be most efficient with those tools and resources. And today we're going to try to dive a little deeper. We're going to talk very specifically about a couple of opioid risk assessment tools, as well as what it looks like to implement opioid risk assessment throughout the healthcare continuum from the perspective of both a patient and healthcare providers. So as we dive into that, I just hope that you will be brave and courageous and chime into chat, use the question and answer box. Let us know what you're seeing in your state, your practice sites, and what best practices you might have seen that you're working to incorporate or you would like to incorporate in the future. Because as we all know, the landscape around substance use disorder treatment has changed very dramatically in the last 5 to 10 years in ways that are really positive, I think, for patients and their outcomes, but in a way where providers have really had to advocate and be nimble and be very flexible and fluid in their understanding of patient need around substance use disorders, and expand our compassion and our tools and change our language. And so this is a really dynamic area, and hopefully we'll be able to talk about some of those barriers and opportunities in healthcare as we move forward today. So the two tools I wanted to highlight today and just talk deeper about are the Brief Risk Questionnaire and the Opioid Risk Tool. These are both evidence-based, heavily validated in clinical research tools that take just a few minutes to implement for all patients who are being treated either for suspected substance use disorder, opioid use disorders, or people who are just there seeking treatment for chronic pain, so that you can get a good idea of what their actual risk for opioid use disorder could be, so that you can help build in guardrails for them and have a very patient-centered approach and discussion around their goals and their unique risks, so that we can keep better track of our patients in a way that, again, is very patient-focused, respectful of the individual. And there are pros and cons to each of these, and we'll talk about that. So the Brief Risk Questionnaire is a 12-item questionnaire. It is drawn from the categories developed from the Brief Risk Interview, which is a much lengthier tool that was tweaked to make it more practical for clinical use, because there's a lot of recognition that patient encounters are short, and we cannot do something that is going to take 10 or 12 minutes, because that's the entire visit. So this 12-item questionnaire can be completed by a patient, either in a private space or even just on your waiting room, using your Freeza tablet. All of those tools and resources we have available in many places. You can have them do this prior to their appointment, and then it can be scored either by the provider or by a trained staff member to give us some concrete facts around the areas of risk and concern for an individual patient. I like the BRQ because it removes some factors that are important but can be problematic. So things like gender is less confusing in the BRQ. Some of our cultural beliefs are removed as variables. And when we talk about the opioid risk tool, you'll see that tool, for example, is designed for patients, adult patients in primary care settings, and it's specifically gendered for male and female patients. And it's designed for non-pain patients. That's where it's validated. You can still use it for your pain patients, but it's not as robust in the evidence saying it works well for them. And I find that that dichotomy of male and female is very problematic, especially as we talk about gender spectrums and norms and how a person identifies. There's not clear language to help us guide someone who is non-binary or was assigned female at birth and is male. Those sorts of people are not well represented in all of these tools. And that can be problematic because we know that changes their risk scores in terms of developing substance use disorders and having behavioral health issues, because our society is a little slow getting our tools and resources built up for those folks. So brief risk questionnaire is a little bit longer than the opioid risk tool, but doesn't have quite as many cultural and gender values built into it, which can be nice depending on your patient population. So looking at those, this is a snapshot of the opioid risk tool. Deb's asked a great question in chat. Do you currently use either one of these tools in your organization? If you don't use them, do you use something else? We would love to know what it is that is being utilized. Many of these can be translated into electronic health record forms. You can turn on alerts so that if you're prescribing an opioid, it can automatically cue you to perform one of these quick assessments. It can be part of your scheduling process. We're curious to know what your experience is around opioid assessment tools. But you can see here, this talks about age, pre-adolescent sexual abuse is important for females. And these are all just identified risk factors where we know a person's risk of developing substance use disorder is just slightly higher because of a lot of complicated social and economic factors. I don't have the full brief risk questionnaire available. It is copyright. And so I do have it linked there to where you can access it and take a look at it. But in order to include the full thing, we were waiting for author approval and unfortunately haven't been able to hear back from him. But this is a really wonderful tool because it's very quick. Yes, no, it uses some Likert scales with that never, a few times, several times, many. And both of these tools, you just simply score very quickly, and it's very intuitive. A higher score means higher risk, and it helps you hone in very quickly on what are modifiable risk factors and what are not. And so you can start looking at how to have those discussions with your patients so you can help them modify risks that are modifiable, and then have good conversations around those that are not, and really talk concretely with a patient about their individual risk in a way that can be clinical and non-judgmental, feels a little scientific, which can be nice when we're talking about things that are sensitive, right? We don't want to ever have patients feel accused of being a drug seeker or misusing their medications, because that can change their confidence in the healthcare system and their willingness to participate. And so the way we approach these things and the way we phrase them, it's really helpful to be standardized and well-trained so that you can treat it very similar to other health indexes. When we talk about pulmonary disease, we talk about pulmonary function. When we talk about diabetes, we like to talk about hemoglobin A1Cs and people's glucose meter and how often they're testing. We have all of these things that are not related to our moral ability to function in the world that allow us to talk about disease in a way that is non-judgmental and is not blaming a patient. And so I find that tools like the ORT and the BRI can really help have those conversations in that same sort of clinical mindset of, I am concerned about your wellness. We need to evaluate your individual risk without changing the confidence that our patients have in our healthcare system and making them feel targeted. There are many validated tools that exist. It's nice to pick something that's validated because then you know it will pretty consistently work from patient to patient. You can feel good about picking one for a large practice and integrating it and using it for everyone, because often there's information out there that lets us know, yes, this will work for my individual patient population and the goals of my practice. And so here's 4 more on your screen here, 5 if you count the SOAP and the SOAPer as different. And they all have small differences that really do help tailor it to individual clinicians and your practice setting so that it meets the needs of both the provider and the patients in a way that feels comfortable, because maybe you don't want to be clinical and scientific about your patients. Maybe that is not your style. And so this gives you an opportunity to look through and see what best meets your needs. And then the important thing with these screening tools is that you apply them to everyone and every situation, because we are simply not good at looking at individual patients and knowing who is at risk for opioid use disorder and substance use disorder. People come in all shapes and sizes. And so this allows us to just be a little more thoughtful and do that universal screening, which is so key to catching everyone who needs risk reduction. So you're going to hear me talk a lot today. This is where we're going to really do some nitty-gritty discussions around what's working. And again, I hope that you'll be willing to chat in and talk to us. But I wanted to talk about what this looks like for patients and some of the best practices. If you hear things that you're curious about and we don't have the resources on the slides for you, please let us know and we can make sure we get those to you. But when we talk about people who are accessing healthcare because of pain, lots of things have to happen for them to successfully get all the way from their home environment all the way to completing their therapy and feeling better about that pain, meeting whatever their patient goals look like. So the very first thing that has to happen is the patient has to recognize that they have a need and that healthcare can help meet that need. So there's a lot of components that fall into that. You have to be able to advocate for yourself as a patient or have someone that can advocate for you. You have to have access to healthcare, meaning that the right person for you is available in a way that works for you, whether that be in person, on the internet, using telehealth. Those things have to be in place and the patient has to be confident that this will work. And as you can see in chat, Deb's going to have our host here help put all of you as panelists so that you can come off mute if you would like. So feel free, as she promotes you to panelist, to come off mute and interrupt me. So our patient identifies their need, is able to advocate for themselves, and they go ahead and they get a hold of the provider of their choice. The very first interaction is one of the first places where this can go sideways, in that reception is the first voice interaction thing that they encounter that can start building the relationship that we have with the patient. One of the programs that I really like is called the 6 Building Blocks of Opioid Use. And it was funded through a grant program and is primarily ran out of Washington State. But it is a team-based care approach that allows people to think really hard about the interactions we have with patients and how that impacts their chronic pain management. And one of the tenets that I really like there is that that interaction starts right with reception. And so when a patient calls needing a consult for chronic pain, having a new injury, or needing a medication refill, this is an opportunity to start having those good interactions and building trust. Mainly, we all know there are notes in our patient files, and that can create friction because if you have, for example, I've practiced in pharmacy for a while now, and in the past, we would have little alerts saying this person frequently refills early, or count pills in front of them. These things that are truly helpful staff information, but also can really color our interactions that we have with those patients. And so find positive ways to have that information available to the people that need it, but also in ways where it doesn't necessarily have to color that initial interaction, so that reception can truly be welcoming, and schedule people and then maximize this time to start that screening process. When a patient gets an initial appointment, that's a great time to include in their paperwork an initial assessment, so you have that information when they come for their appointment. It also can allow you to do some pre-planning. We love to do all of those things when we're talking about chronic care management and improving patient outcomes. This is an excellent time to grab more data so that you can have a more efficient, productive appointment with that patient. So then we get them there and they have their appointment. And at the bottom here, you can see I have patient, reception, clinic staff. These are the people that are sort of involved in each step. And I want you to pay close attention to those times where the patient is alone, because again, they need to be able to advocate for themselves. And we should not assume that our patients are always in a place where they can advocate for them. And so we might have to build in safety nets for those sorts of things. But looking at all of the different people that touch a patient who is experiencing pain is a lot. You have to have a team-based approach because it is a big team, and many people are pretty pivotal here, including the patient, the provider that they see, any specialists that we need, and then pharmacy staff, I feel like are all very important. So when they're coming for that visit, another thing that should happen in between reception and that visit is we should be checking the PDMP. All of those tools and resources that Kevin had shared with you, ways to make that simple, that should be occurring for every patient every time, because again, you need that data to be able to make good decisions with that patient. So we see them in the office, and then we assign them a lot of follow-up care. And I would be curious, as I'm chatting here, for you to chime in on what pieces you feel like are happening in your system, where the holes happen, and any other best practices you have heard of to make this go smoothly. Like, do you have a champion that talks to people about chronic pain? Do you have certain providers? Are you referring your chronic pain patients to a specialist? Are those even available in your community? We would love to know a little bit more about what that looks like in our different practice sites, so that we can be a little more aware at Mountain Pacific what our resources look like in the Mountain Pacific region. So we see our patient. We've hopefully done all of our homework. We've done a risk assessment. We've looked at that information. We've looked at the PDMP. We have a really good idea of what our patient is on and what their needs are. And then we build goals with them. And a lot of times those goals require extra information. We might need imaging, we might need labs, they might need to see a specialist, but always there's homework for the patient, right? That might be PT, it might be going to the pharmacy. Because we're talking about opioids, you can't get opioids typically without going to the pharmacy. And so we also send them to the pharmacy. And the pharmacy repeats this entire process. Pharmacies can absolutely do opioid risk assessment screening with their patient. There are many ways this is automated. If the PDMP happens to be hooked in with different algorithms like the NARCS care that helps identify patient risk, those things should be happening. But also you can use these tools like the opioid risk tool to have those conversations at the pharmacy as well. If you choose to do that, it's excellent patient care, but you do need to have a plan for what you do with that information afterward. That's absolutely a pharmacist's role, to have a good conversation and then make sure that patient leaves connected to resources they might need. Because when we're asking them all these questions, we have an onus to help them find their referral network if they need that. So they visit the pharmacy. Again, they're put through the ringer of opioid risk assessment, looking at the PDMP, talking about risk. There is an opportunity there for pharmacy and the prescriber to have had some of these conversations in between, oftentimes because of corporate policy or legal statutes in a state. There can be a delay at this particular junction because all of this, again, is fluid and changing and very unique to individual states and practice settings and the pharmacy of choice for the patient. That can be frustrating for the healthcare system because Walgreens might have different rules than CVS, might have different rules than Kroger, than Walmart. And that is a time waster. It, just to be very frank, it creates a lot of confusion for patients and providers and can fracture this team-based care. And so this is one of those important points where sharing information, being gracious, assuming no ill intent, can really help us take better care of our patients because it's complicated. So finally,
Phoebe, I'm going to interrupt you. This is
yes,
Kyla.
please do.
I just wanted to add a little bit of input on that pharmacy piece. And when these patients may present to your pharmacy and you haven't been involved in their care so far, maybe it's a new pharmacy for them, or maybe you just haven't been involved in the decision process or in the risk assessment process with the provider from the beginning. And if you have suggestions on how to kind of maneuver that and tactics that you can use to make the patient feel so they're not stigmatized, because I think a lot of times that'll happen when you have a new pharmacy involved and they don't necessarily have all the background information that they need to really take care of that patient.
Yeah, that's an excellent question. I'm glad you brought it up. I think one of the best things we can do is to work on our bedside manner and involve the patient at the very beginning. If they're new to you, you can use that opportunity to build some rapport and just walk them through, like, we're glad you're here. We're going to take good care of you. Here's the process that our pharmacy uses for this particular medication. See what the patient can offer that can help you. Patients are often excellent historians. If they have been on opioids in the past, they're familiar, for better or worse, with sort of the hoops that we make them jump through, and involving them in the process right from the beginning and being transparent about what you need seems to help diffuse a lot of that. That's not a perfect solution for everybody. Obviously, there are people that still feel like that creates a bad experience for them. But I do find that just being very clear and concise, like, these are my specific concerns versus these are the rules that my employer asked me to follow, I think can help build trust. That because oftentimes when we're doing those pieces, we have to explain that, yes, your doctor wrote for this, and we know that they want you to have it. In order to dispense it, I am legally or by my employer required to gather these pieces of information, and I anticipate that will take, however long you anticipate it will take. Involving them in that process respectfully throughout the entire thing and getting what information you can from them at that time to sort of expedite it seems to help the most. And then I think there's just a tremendous amount of education that has to happen if it is a new pain patient, because getting an opioid from the pharmacy is not the same as getting metformin for your diabetes. And so we have to walk them through that process. I feel pretty strongly that all controlled substances should have those sort of guardrails built around. so that hopefully people will start feeling like this is related specifically to the class of medication and the risk it presents to patients rather than individual patients. And that's where like having universal standards for how you treat people is a really great place, so that they do not see you treating them different than another patient, because they are going to observe us. You know, in the pharmacy, we're in a fishbowl. People can see what's going on. We do our best to protect privacy, but that patient's perception is the most important thing. And so if they perceive that they're being treated equally, it just gets everybody off on a better footing. Does that help answer that question, Kyla?
Yeah, thank you.
Yeah, you bet. Saying if other people have questions, please feel free to hop in. You can come off mute, or you can chime it into our Q&A or into our host and panelist chat. So another important thing that happens after the patient gets the medication that sometimes is forgotten about, this should happen with lots of things. Antibiotics are one of them, pain medications, new therapies. We should give the patient a trial of treatment, and then we have to follow up with them. How is it going? Like, are you experiencing side effects? Is your condition improving? Were you able to successfully connect with that referral provider? Did you even pick up your prescription? Just in general, when we write a prescription, whether it's electronic or physically written for patients, 30% roughly of those prescriptions are never picked up by patients. And so this is just a good practice that needs to happen again universally to see, are we getting the expected results? Because this system is full of holes and hangups and issues. And we didn't even include any of the payer information in here. You know, we all know that insurance can stop that primary care visit because now that person is not, there's not a contract with their payer. So they need to find somebody who's in network. They don't have a lab that's in network, so they have a delay getting labs, or there's not a lab in their community and they have to travel for that. Availability of pharmacy, having something being on formulary, being affordable, all of these things create a lot of opportunities for holes to be poked in the system. And it takes a really motivated patient to get themselves all the way from, I know I have a need, a doctor can help me, all the way through to follow up, and possible many cycles might be needed to complete this. And so if we're not careful with our approach there, if we make the patient feel stigmatized, don't have a good standard of care approach to where they feel welcome and wanted, and like their goals are our goals, they can fall out of this circle very, very quickly. So I wanted to give Kevin just a little bit of time today also to talk about what happens when we use our PDMP, how things change, and who is accessing the PDMP. Just to give you an idea, we know at like a national level that most people are not doing these opioid risk assessments for every patient every time. We are having better luck with PDMPs, and that's where we're building in a lot of that electronic assistance to help have algorithms to talk about risk, so that hopefully if you're not able at this time to incorporate standard risk screening and those conversations, at a minimum, you can effectively use your PDMP. So I'm going to pass things along to Kevin now and let him talk to you about outcomes when it comes to PDMP.
All right, thank you, Stevie. If you could go to the next slide. Stevie just spoke about the interdisciplinary approach to pain management, showing all the different disciplines that can be involved. And this slide really just shows how that comes out to be in the real world. This shows Nebraska's data specific, and don't pay too much attention to the numbers, but the slices of the pie on who is querying. You have physicians, APRNs, PAs, dentists. Dentists are starting to use it more and more. And then if you look at the green section, that's delegates, because as most of the states on the call have requirements to either mandatorily enroll and register in the PDMP or actually query. CMS has requirements for Medicaid beneficiaries to be queried if providers prescribe controlled substances. And this just shows how different disciplines are actually using it and helps break down that Swiss cheese model where something can get missed, where you have the prescribers, the clinicians using it, but you also, in this case, showing almost half of all the queries are performed by pharmacists. And they may do it, as Stevie mentioned, through their pharmacy organizational policies. It may be required for pharmacy chain X to use it for all controls. Some may do it for specific opioids. And some will use it just because they understand that it's a valuable tool. If you go to the next slide, as Stevie's been talking this whole time about risk assessments and opioid risk tools, the PDMP is a tool that can actually be used for this. And in your PDMP, you may see where it's called a risk score or a risk assessment. I prefer to call it a clinical assessment because it's just one of the multiple assessments you use for that risk score to see where your patient may be. And a lot of this information comes basically from the CDC in their 2016 guidelines for chronic pain. And that's been somewhat controversial when it came out in March of 2016. It's been good information, but it still has some challenges. And CDC, as some of you know, is going to publish a new document. Right now, it's tentative for the end of this year. They had their request for comments in the Federal Register that closed about 3 weeks ago. Now they're going through reviewing all of those comments and trying to focus mainly on 18-year-olds for either subacute, acute, or chronic pain. They're going to try to narrow it down, focus on evidence-based medicine, and modify their 12 recommendations that they have for some of the prescribing for pain in different settings. One of those, the recommendation number 9, focuses on the PDMP, on how beneficial it can be, on how it should be used. But they talk throughout that current document from 2016 on morphine milligram equivalents, MMEs. So this is a common assessment that's within these tools that you can find. This just shows visually or graphically, because I'm a picture person when I look at mine, and you'll be able to see something similar but slightly different in your PDMP, but it still has the same concept. You might have a score that it has. You might be able to see graphically when those prescriptions for opioids had been dispensed. And if you go to the next slide, you can also look at one of the CDC's recommendations for monitoring and not recommending the overlap of opioids and benzos. This also pertains to not only benzodiazepines as an overlap, because in Nebraska alone, about 20% of all drug overdose deaths are due to benzodiazepines, either alone or in combination with opioids. But we also see this with antidepressants and antipsychotics. CMS, through the Support Act of 2018, requires Medicaid to track and monitor those who are on overlapping opioids and antipsychotics. And once again, this just shows graphically and visually where that falls on, is your patient receiving an opioid and benzo, and where within that period of time, in this, it's 45 days as an example, where that falls. So your PDMP is going to have, as a tool in its entirety, these assessments, these risk scores that are going to be able to help you manage your patient and help you make those clinical decisions for the best pain management. And Stevie, I'll turn it back over to you.
Thanks, Kevin. If you've paid attention to Kevin's and my language as we've moved through this series, you can see like the adoption of new language in action, because Kevin is very thoughtful about talking about clinical assessment and clinical tools, and I still use the word risk. And I think this is an important area to really start thinking about how we work on our language and the ways that that impacts our patients, because patients are so quick at picking up small things and and our words impact our attitudes. And so I apologize for using the different language, but it's just another unique thing I feel like to talk about when we talk about like mental health issues in general, and respect for patients and being patient-centered. We always have these opportunities to pick up nuggets of goodness as we move along. And so thinking about that language and the purposeful way that Kevin speaks about destigmatizing our language around opioids, I think is really, really helpful. And if I hope that's a takeaway that other people get as well, because those everyday interactions with our patients can really be meaningful there. And I'm never ashamed to steal shamelessly from excellent colleagues. So this brings us to the end of our third session. I appreciate you hanging with us as we went a little long. We have some burning questions for our audience at Mountain Pacific. Specifically, we want to know if people would be interested in some technical assistance or targeted work groups around screening for opioid risks, opioid use disorders, looking at specific EHRs, or particularly in Wyoming, if you are a Works subscriber, so that's the name of our PDMP, you've likely started to receive information about the transition from Atlantic Associates, who currently manages the PDMP, to Bamboo Health. And through a combination of a lot of groups, including the GWEP and Mountain Pacific Quality Health and the state of Wyoming and the Board of Pharmacy, there are opportunities to get together and start talking about how that system is going to be improved for healthcare providers, and ways that we can improve patient outcomes. And so if you are interested, regardless of what state you reside in, regardless of where you work, if you would include just a little chat and some contact information, letting us know that some of this targeted information would be beneficial, we would really appreciate that. If you can do that either as a private message to the hosts and panelists, or you can just pop it in there for everyone. If there are any questions, now is the time. Please feel free to take yourself off mute, ask your questions, or pop it into chat. All right, well, thank you everyone for your attendance today. It doesn't look like we've got anything coming into chat. Feel free to reach out to us. There is our contact information on the screen. And thank you for attending our third session.